glad to welcome Dr. Richard O'Reilly, a professor of psychiatry at Western University. He graduated from Trinity College Dublin and holds qualifications in psychiatry from the Royal College of Psychiatrists in the UK and the Royal College of Physicians and Surgeons in Canada. Dr. O'Reilly has extensive clinical experience and continues to work with patients with severe mental illness. Welcome. Thank you for joining us.
Thank you very much for having us, Ms. Murray.
I know one of your interests is law. Would it be fair to say that all people are entitled to have basic medical care as a human right?
I think yes, as a human right, that's a very important thing. It's not, as far as I know, in anywhere written into law, but in terms of our international understanding of our obligations to to the population, people who have serious health problems deserve to have access to healthcare.
Yeah. It's just so puzzling because our particular interest in the Mothers for Mental Health Care reform is people who are living with schizophrenia. And we see such a contrast. We wouldn't let grandma run in the middle of the street in a snowstorm or something. Why do our society lets people with serious mental illness do that kind of behavior? How do we understand these differences between dementia and someone with a serious mental illness?
Well, this puzzles me. It puzzles everyone. I spend a lot of time talking to families of patients who've got serious mental illness, and they, many people have this concern. I think one problem is that people with dementia can't state their needs very clearly. Some people with severe mental illness, though, do state what they view as their needs. These are, of course, in some instances, severely distorted because of the illness, leading them to do things which cause harm to themselves and, unfortunately, sometimes to others.
So speaking up for themselves, is that what you mean? They can speak up and ask?
Yes, they can speak up, but of course the thought process of people with very severe psychotic disorders is distorted by the illness, and so these are individuals who are quite vulnerable because they don't recognize the need for treatment and for care provided by society, and they don't ask for that. And unfortunately, what's happened over a period of 50, 60 years is that there's been what I call an unholy alliance between the extreme left libertarians who say that these individuals should not be treated against their wishes, and of course right-wing fiscal conservatives who are delighted with that and who closed all the large psychiatric hospitals and didn't put services in place which are suited to that group who have severe psychotic disorder.
To actually meet their needs, right?
Exactly.
But you mentioned about the lack of insight, and it has been said to me that no amount of arguing will convince a person who lacks insight that they need to take treatment. How is lack of insight seen in the emergency room typically if patients are completely out of touch with reality and present at ER?
I think sometimes the ER physicians and nurses are actually excellent in recognizing lack of insight, but at other times they struggle with the concept and with, I guess, determining that people have sufficiently impaired insight that they are not legally capable of making decisions for themselves.
So is there some confusion with being intoxicated or being on some kind of recreational drugs? Is that why they have the 72-hour?
The confusion with insight is more over the conceptualization of what that means and what the test is, the legal test for capacity. So in Ontario, an individual for any treatment, be it medical treatment or specifically psychiatric treatment, dental treatment, a person to be capable must understand the information necessary to make a treatment decision and be able to appreciate the likely consequences of taking the treatment or not taking the treatment.
Right, and the consequences of not taking the treatment, just as you said, right? Exactly. It's hard to foresee.
Well, sometimes from psychiatric perspective, it's actually very easy to see what the consequences are going to be. But for some patients, some individuals with psychosis fail to appreciate that they're ill and that without treatments, their lives are going to go downhill and potentially very detrimental things are going to happen to them.
Right. And not just to the patient, I guess, it affects the whole family. Now, I've read that lack of insight affects a great majority of people, and we're particularly interested in those with schizophrenia, psychosis, bipolar disorder. It's more than half of the people with schizophrenia lack insight. Those are the figures that we've read. Does that seem correct from your practice and day to day?
I would say that I would agree with that in general terms. I might make a distinction between full insight and legal capacity. So I've already given you the sort of basis of the legal capacity test in Ontario. Some people can make that, but still not fully appreciate where they are in life and what they need because of the illness. But from applying the legal capacity strictly, somebody who has a delusion, a fixed false belief, and not shared by their peer group, would lack the capacity to make a decision for treatment of that delusion, because the delusion is fixed. So as you say, when somebody is actually deluded, they no amount of logical arguing with that person will convince them otherwise.
Mm-hmm. It's such a puzzle. And the Mothers for Mental Health Care Reform, we see this lack of insight as a major barrier to healthcare. It's confusing to explain to our relatives and friends, neighbors. Actual lack of insight is much different than a conscious decision to minimize or deny or just refuse the facts that they know. Sometimes people are reluctant to take medicine for their diabetes, take the medicine for their alcoholism, and so on, but they're acknowledging their own preference, that this is maybe not in my best interest. Families feel so frustrated because we see treatment as medically necessary. It's quite difficult. You have such experience as a psychiatrist. How is treatment determined? In this case, it's medically necessary for the patient.
Well, most individuals with psychotic illness actually are quite happy to take treatment. Many want treatment because they are, tortured by voices, or they are, very distressed by mood impairments. So, many people voluntarily take treatment. Other individuals are willing to take treatments, but lack of motivation is a prominent feature in some psychotic illnesses, such as schizophrenia. And so that sort of overlaps a little bit with, with lack of motivation we see in some other medical illnesses, such as diabetes, but it's much more pronounced, and it's actually a feature of the illness. So that complicates things. And then there's a very difficult group of individuals, very difficult to treat, because they not only don't appreciate the need for treatments, but their delusions and voices direct them in a certain way. They're paranoid about the healthcare services, they're paranoid about the family members, and absolutely refuse treatment.
So they think they might be poisoned by the healthcare professionals, or
Exactly. Or they start to believe that family and friends are plotting and scheming against them. So they may leave, a secure home where somebody has a wife and children, and go on the streets and try to avoid all contact with people who care for them and who would look after them.
Well, as you say, psychiatrists evaluate the capacity for the patient to make their own decision, whether they have that capacity to make a decision about antipsychotic medicine, just by speaking and having a discussion with the patient. Um, Not all psychiatrists have the years of experience, and I know you particularly have an interest in schizophrenia. Other psychiatrists maybe who aren't as equally skilled in making that judgment. There are different assessment tools that we've read about in the literature, the academic literature. Can you talk a little bit about like the aid to capacity evaluation? I see that's from Dr. Etchell at Sunnybrook. There's quite a number of them, which is just kind of maybe probing at each of the stages you mentioned.
Yeah, I wouldn't, I don't use these tools. I think they're more useful for research purposes. I don't think that they are easy to use in a clinical situation such as an emergency room where there are time pressures. But Ms. Murray, the thing I would say is that it's not actually that difficult to determine if somebody is incapable. Again, the legal test is that the person has to be able to understand the information necessary to make the decision. Often that's a problem in dementia rather than in psychotic illnesses. But the second part of the legal test is that the person must be able to appreciate the consequences of making a treatment decision, the foreseeable consequences. And it's often at that point that the person fails. And I think that that's relatively easy to do. There is I guess, a range of opinion about how impaired capacity must be, how impaired that inability must be before somebody declares a patient incapable. But I've said something here which is, I wanted a message out to people, so I'll say it again, that an individual who has a delusion, a fixed false belief, where that you can't in no amount of logical argument can convince that person that they are deluded, that they are wrong, that that belief is false, and that's the definition of fixed false belief, not shared by the peer group. That individual cannot logically be capable of consenting to their own treatment. And so I'm challenging the system, my colleagues, to think about that, because I think that we have lowered the bar unnecessarily and harmfully in the care we give to people.
Very interesting. And I know that when we say that they're not capable to consent to treatment, it means the corollary that they're not capable to correctly refuse the medicine as well. Um, it's quite an interesting point for our group, the Mothers for Mental Health Care Reform, because we see that our relatives who have severe schizophrenia really will not recover on their own without medicine. Um, it's quite a tricky situation, and it seems to be um, changing a bit maybe in society now that we have so many people that are homeless, and we know that a lot of the people who don't have places to live, a great percentage of them may have some kind of mental health disorder, diagnosed or undiagnosed, I suppose.
Research suggests that that number, that percentage, is somewhere between 20 and 25%. So between a fifth and a quarter of all individuals who are homeless have a psychotic illness. Psychotic illness. So nearly everyone who's homeless, the vast majority, have some form of substance abuse, but 20 to 25% have a psychotic illness. And of course, they may have comorbid illness with both psychosis and a substance abuse disorder.
Mm. And with your experience over the years, maybe could you talk a little bit about patients who have recovered well? Is there kind of a range, a percentage? What happens when people are able to keep up with their medicine?
So probably a simple way of portraying prognosis is that a third of individuals with schizophrenia have a good prognosis. Some of that thirds will have one or at most two episodes of illness and not be affected afterwards. The next group, the next thirds, tend to have relapses and remissions, and that's very significantly affected by whether or not they adhere to medication. Because certainly after a second episode, I think nearly all of my colleagues would say that the person needs to stay on medication lifelong, because the risk is just so high of further relapses. But unfortunately, there's the last third, the bottom third, have a very poor prognosis, and many need to be in long-term care situations. When I say long-term care, I'm not talking about a long-term care home, but they need ongoing support. And when deinstitutionalization happened, there really wasn't any well executed research that looked right through the levels of people. There were some early studies that looked at individuals who, most of them came from that best prognosis third, and they did well when they were discharged from hospitals. But as we shrunk down the size of the freestanding psychiatric hospitals, we ended up with discharging people who really needed asylum, by the full meaning of that word, long-term care and support. And now,
supportive housing in the best sense of.
Yes, I think supported housing is a little bit of a hackneyed phrase. It's bandied around as if, it's just a single thing, but there's a group of individuals with psychosis who now are not in hospitals. They need round-the-clock support, round-the-clock nursing support. They probably need to live in a controlled environment, which they need to be in by curfew. They need certain rules because otherwise they're on the streets, even in the dead of winter. They are vulnerable to people in society. They abuse drugs or offer drugs, and of course, many young females fall prey to pimps and end up in prostitution. So this is very unfortunate, and we're turning a blind eye to it. But we need supported housing. We need a range of supported housing, but some with very well staffed and regulated, and with careful controls. And we haven't even begun a conversation in Ontario about how that can happen.
Definitely, very important issue. I know that many of our mothers in our group are told that when there's a relapse, our relatives can only be admitted to hospital if they're an actual danger to themselves or a danger to others. And in the regulations, there's that criterion of deterioration, but we're not clear about how that's defined. Or I know there was a recent case in the national news where the particular patient had been actually at 4 different hospitals, 4 different emergency rooms over quite a number of months. And yet each doctor felt that maybe they weren't likely to come to any harm somehow. And eventually, the last place did manage to provide treatment, admit the patient, and so on. It's come out with a positive story at the moment. So how is that? What's that gray area there about whether they're likely to deteriorate?
So I think you may be talking about the Andrew Branton case. Is that the one? Yeah. So I've written elsewhere about that case, and my understanding is that Mr. Branton, a gentleman from Prince Edward Island, who had been diagnosed with schizophrenia, ended up in Ontario. My understanding is that before one of those assessments at hospital, he had walked up an off ramp onto one of the 400 series highways, which actually is something that puts his life at risk and the lives of others at risk. And so, in my view, Mr. Branton would meet the criteria for being at risk for substantial physical deterioration. Because if he's hit by the car, he might die instantly, or brain damage, etc. So I think that case was badly handled and assessed based on the information I have. But you are absolutely right that a person does not have to be posing a risk of physical harm to themselves or another person in Ontario to be admitted. They can be admitted if there is a risk of physical or mental deterioration due to a mental illness. There are some other riders that need to be met for a person to be admitted in this situation. They must have been treated before and responded to that treatment. To be admitted because of risk of mental or physical deterioration, they must be incapable of making a treatment decision, and the physicians must have the consent of the appropriate substitute decision maker. The problem, Ms. Murray, is that we do not have enough beds in Ontario to admit all the individuals who would meet those criteria. So time and time again, individuals who would benefit from treatment and who are highly likely to deteriorate, and maybe not only mentally but physically, are brought to hospitals, to hospital emergency rooms, and turned away, basically. And the reason is that our beds are totally full. We do not have enough capacity in the hospitals to treat all the people that need treatment. And furthermore, bed shortage is so acute that we are discharging people prematurely. And this is why individuals in 2024 are being discharged to homelessness or to a shelter where 20 years ago, the treatment teams, the psychiatrists and nurses and social workers would have made a discharge plan with an appropriate placement where the person might actually thrive, might actually be safe, might actually not be recruited into prostitution or be confronted with people pushing drugs on them.
So you really feel that it's a resource shortage. It's not a problem with our regulations. Or do you see any particular laws or legal changes that need adjustment or improvement?
So Ontario's law, Ontario Mental Health Act and Healthcare Consent Act have some flaws. I'll talk about them, but let me just emphasize, I think that most of the problem is resources, lack of resources. But we have a absolute horrific component to our legislation, our Healthcare Consent Act, which stops people being treated who are admitted involuntarily to hospital because of risk of harm to self or others, or risk of deterioration, and are incapable but challenge that incapacity. As it currently stands, a psychiatrist cannot start treatment while an appeal is before the courts. And so some of these appeals go from one level of court to the next, and occasionally all the way up to the Supreme Court of Canada. So the average time to resolve one of these cases is about 5 months, but we have had cases that it's taken 2 years.
Oh, wow, that's amazing.
So, and this is occurring 70 plus times a year in Ontario. And colleagues now are not admitting people because they know from past experience that this person will appeal to the courts, or they have characteristics that suggest that they may. So Many people are not even admitted or discharged prematurely before this whole scenario unfolds. And research that I've done personally shows that really nobody benefits from this. So it's not that let me put it this way, once the Consent and Capacity Board says that the physician was correct and the person's incapable, there's almost no cases overturned. But there are, in a space of 5 years, there are hundreds of people who have their treatment delayed, and during that time, there are assaults on the ward. There are disturbances on the ward with people shouting out. There are assaults on relatives. The patient deteriorates further. It's a terrible situation.
It's a terrible situation and it's expensive situation because each of those things you just mentioned has a cost. When the nurse gets bopped with an elbow and the police have to be called to the ward, and paperwork, I'm imagining. There's so much of this relapse that they call it a revolving door.
Yeah,
Do you feel that if people had medicine, had antipsychotic treatment, maybe supported with CBT or whatever's appropriate, that the expenses would be less for our society?
Absolutely. I'm just going to go back for a moment to the nurse who, as you say, gets bopped. We shouldn't accept this. I mean, our nurses, I worked with nurses over my whole life. I've worked in hospitals all my life, and they are, we were saying in COVID, they're healthcare heroes, but our nurses working in psychiatric hospitals and emergency rooms are regularly assaulted, and sometimes very seriously assaulted, and never return to their job. So, I mean, I think it's important that people keep that in their minds. And the other thing, Miss Mary, that I'm only too aware of is that the people most often assaulted are family caregivers. So when individuals don't receive care from hospitals and the healthcare system, it falls to family caregivers, and it's the family caregivers often in these situations, somebody untreated who gets seriously assaulted.
That's definitely what we're all about. Mothers for Mental Health Care Reform is these tragedies are preventable.
Yeah.
One of our parents was asking, do you agree with the view that some have said clozapine should be the first approach to prescription for serious, severe mental illness with psychosis?
I do not agree with that, but what I do agree with, and other people said, and we have it in our standard of practice, that clozapine should be considered if two course of antipsychotic treatment do not work. So clozapine has excellent evidence, and it's absolutely the best antipsychotic medication for so-called treatment refractory schizophrenia. So cases where the patient hasn't responded to one or more courses of treatment. The reason I wouldn't use it as a first line treatment is that it's a difficult drug to use. It's got a lot of side effects. Not only the problem with blood dyscrasias, agranulocytosis, which occurs in about 1% of patients, and with monitoring, we can rapidly move in, stop the drug, evaluate the situation. But it also has serious cardiac effects, which again, in a very small number, but they are serious, and a lot of very problematic side effects for the individual, such as excessive salivation, which can be quite distressing for the person. So I think it's reasonable to try other drugs before looking at clozapine. But clozapine is underutilized, so many colleagues are unwilling to use it. Maybe they have lack of experience, but the evidence is very strong, and evidence out of Finland shows that people on clozapine actually live longer than on other antipsychotics. That's because of its effectiveness, extra effectiveness.
And I know several cases where people are, holding down jobs and attending recreational activities and managing very well. Yeah, it's so individual. But is it known in science whether the experience of frequently stopping and starting psychiatric medication, does that have an effect? So I read that every time there's a psychotic break, that there's loss of tissue and so on. And it's hard for us to know whether these research findings are relevant or important to us.
I actually don't believe that that is proven. It may well be true, but I'm skeptical about studies that purport to show that. So various medications can cause or associated with. I shouldn't have mentioned cause because it's so difficult to show that. You need to do a randomized controlled trial. But the use of certain medications are associated with shrinkage of certain parts of the brain, but increase in size in other parts of the brain. And what this means, we don't really know. That may be fluid retention in those parts of the brain. It may be cell loss, but without biopsy, it's very difficult to say. What we do know is that starting and stopping medication is associated with poor prognosis. And again, people who have certain characteristics, amotivation, perhaps paranoia, perhaps a poor support system, will have, may have, are more likely to have poor prognosis, and they're more likely to start and stop medication. But starting and stopping medication disrupts your life. So I'm sure your group will know situations where individuals have been relatively stable, stop medication, lose a relationship, lose their job, lose their housing, and it's only when they get treated they have to start again. And what we see is over time that's harder and harder to do. So that may be from social factors, but there may be a neurotoxic effect at the brain level of actually being psychotic. However, I think it's too early to say that that's proven.
Very interesting. The science is coming along. One of our parents asked the question, I would like Dr. O'Reilly to comment on what I consider to be a disservice to the patient. While suffering from lack of insight, they are discharged from the psychiatrist's care after refusing further treatment. And in the long run, the patient will eventually need a psychiatrist, and yet that discharge leaves them without access to a psychiatrist, to an assessment, to treatment. Is there anything that a family could do to reverse when a patient is discharged? Can we keep them on the books, or how is it done?
Well, Ms. Murray, if a patient says to me, Dr. O'Reilly, I never want to see you again, I don't think it would be logical or expected that I'm going to keep them on the books forever. So if they call, 2 years later, that I'll say, oh, well, you can come in, you don't need a referral, I'll see you. But if, a person says, I never want to see you, Dr. O'Reilly, and 2 weeks later, that person comes in with the family, then I would feel obliged to see them. I think that would be the correct thing to do. So that's a little difficult. But to address, I think there are lots of situations where people are, patients are discharged from hospital or from services prematurely, and the family don't have the support they need to look after their loved one at home. And if that happens and it's inappropriate, I think families should, write to to the doctor or leader of the service to ask why that's happened. And you know, I've talked in other places about this. I think I talked to it in my a lecture I gave to Home in the Hill, which may still be available on the internet, and sets out the stages of doing that. So it's important to just to have the facts and to set those facts out and to keep emotion out of that question. You know, this is what's happens. My brother was discharged in these circumstances on such and such a date. We didn't know he arrived back to his apartment. It was 3 days before we knew he was there, etc. And you know, why was that done that way? And if you don't get a satisfactory response, then you go to the next level, to the head of the psychiatric service or the head of the hospital, the CEO of the hospital, and if you don't get a satisfaction there, to the MPP or even to the media. So
Yes, that was very good information. How to be specific in your letter, avoid emotional statements, avoid escalating it, just stick to the facts, and then to be persistent and keep on writing and so on. But with regards to a patient saying, I'm not coming back, there's no guideline of 3 months or 6 months, or we used to have at one time a roster system where patients were supposed to have an allegiance to a particular clinic, and they would be on the roll somehow. Is that relevant?
It's different parts of Ontario may run their mental health services differently, but there's no place I know at the moment that has that sort of roster. But so where somebody has a family physician, the family physician would be the first port of call, and the family physician could contact that psychiatrist and say, like, would you be prepared, you know the person, would you be prepared to see them in consultation, or, you know, or if the person then is not willing to do that, then you're into a different scenario where they may need to be assessed in the emergency room.
Mm-hmm. Dr. Relly, you're one of the key founders of the FASME, the new group. Our mothers are very pleased to join FASME. What strategies is the group planning to use to teach a wider audience and to rally up the members of the general public, focusing how to adjust policy, how to make improvements?
So FASME, the Family Alliance and Serious Mental Illness, is basically a family caregiving giver organization. I'm involved with it, really in an advisory role, and FASME was founded because at a national level there really isn't a group that is unequivocally speaking with the family caregiver voice. And you know, in Ontario, that used to be the Schizophrenia Society of Ontario, which is essentially now dissolved, very unfortunately. So the group has been really just coming together over the last 2 years. Our website was launched a couple of months ago. It's a young organization, so anyone seeing this video, I'd encourage them to look at the websites, look at the values, and think about joining, particularly if people have skills. You know, we're at the moment looking for specific skills such as financial management and media relations.
That's great news if people want to join in. So again, it's the Family Alliance on Severe Mental Illnesses.
Correct. Mm-hmm. So if you Google that, you should come up with the website.
But at the moment, the people who would read those newsletters and be listening to educational events are the people who are already involved or committed in somehow. How can we get the attention of decision makers to make these improvements?
Well, that is really the reason for the formation of FASME. So The two things that FASME will probably focus on is one, trying to ensure that at each province the voice of families is heard. So at any table where decisions are being made about individuals with severe mental illnesses, there should be a family caregiver voice. And we would hope to promote that and intend to promote that in each province. And so not just centrally, but at any regional committee as well. The one thing that I know that has been a tremendous problem for family caregivers over many years is the failure of the system to appropriately share information with family members. And I suspect that that will be a key policy goal of FASME to get that changed. And that's going to be a difficult thing because it's a culture rather than a legal thing. I think our laws, although I hear people continually saying the opposite, but in my view, our laws do provide a range of ways to bring families into the conversation about ill relatives. And in fact, often it's only a matter of asking or actually talking and trying to convince someone of the importance of having family involvement. So it's a culture that we need to change.
So you're not aiming at the entire privacy laws, but about one-to-one convincing people that we do have a legitimate right to share information with the health professionals?
A common scenario, Ms. Mary, is that a family caregiver like yourself has someone admitted to a psychiatric unit, and the caregiver calls the hospital and says, "How is my son or daughter doing?" And the response, it's like an automatic response, automated, might as well be talking to a phone answering service, is, "We can't give out any information because of privacy." I don't know if that's happened to you, but I know it's happened to others who will see this video. And very frequently, and it's usually a nurse, hasn't gone down the hall to ask the son or daughter if it would be okay to give out the information. And even if they say no, to do a little bit of discussion about, well, this is what I'd like to say, that you're doing well, you've had a side effect, but you change your medication, you're doing much better, something like that. Oh, you can say that, of course you can say that. It's stopped at the phone. And that's even without getting into the issue of individuals who are not actually capable of making a decision to not to share their information with family.
One of the psychiatrists I had been speaking with said that they were trained in the UK and that there's a different culture there. Is it easier to talk about these matters, or are the regulations different?
So I haven't worked in the United Kingdom, but I have worked in the Republic of Ireland as a psychiatrist, and it's much easier to share information in that jurisdiction. And it's, that the culture, society in Ireland is a little bit more family-based than, are very individual-based. So again, beyond the actual legislation, there's just the will and the acknowledgement that if somebody is living at home with their family and they're very severely affected by schizophrenia and their family are bringing them to medical appointments, going to the pharmacy to get the medication, in reminding the individual to take their medication every day, monitoring for symptoms and side effects, providing shelter, providing meals, it's natural that those individuals would want to have information. And barring some unusual situation, circumstances, they should have that information. So to just say, oh, privacy, because of privacy laws, we can't give you the information, it's not actually correct. And it should not be the end of the story. Even if it's strictly correct, there should be some attempt to bring the person around to be sensible and see the why family want to get certain information.
I know one thing that our mothers are often telling is that we can certainly share collateral information, type up very clearly some key points and make copies and make sure that it gets into the hands of people, even though perhaps the patient doesn't want anything disclosed. And at least we feel that we're trying to be helpful, but often again, I think that the privacy legislation has a bit of a chill effect, and I really don't want to add to the nurse's workload and make an issue, but it seems to be kind of difficult to get the information there. I know one psychiatrist told me that no, I don't read emails, so my efforts were for naught.
Well, what I would say is that a psychiatrist like myself has a duty to do the best that I can for each individual patient, and getting information about symptoms, course of illness, side effects, social situation that the person is living in or interacting within. All these are very important. So, if somebody's going to send me an email with relevant information, I'll take it. I think that's my duty to do so. And HIPAA, of course, does say that healthcare providers can collect information necessary to do their job. So I think that the privacy legislation in Ontario is misunderstood. People really miss some of the things in it. The legislation is also very clear that if somebody is not capable of consenting to the release of their information, then that should go to the appropriate substitute decision maker from the hierarchy in the Healthcare Consent Act.
Yes, very, very good, important tip. Is there anything else that we haven't covered that you'd like to mention at all, Dr. Ryan?
What I'd say, it's a very negative thing, I think, to end on, and maybe I'll say something else that's more positive, but I've worked in Ontario continuously since 1989, and it's my impression, and the impression of many of my colleagues, that the care provided to individuals with severe psychotic illness has deteriorated over those years. So I think somebody was much better off in 1989 than they are now, presenting with a psychotic illness. Now, the two caveats, two positive things I'll say is that the first episode psychotic programs have really done a wonderful job. They've been a great thing that brought people into treatment earlier, and many people have really flourished because of those programs. And the second thing is that the introduction of assertive community treatment teams, ACT teams, has also provided wonderful care to many people with severe and persistent mental illness in the province. Unfortunately, there are not enough ACT teams. We are underserviced for ACT teams, and that's just a disgrace, because we should serve the people with the most severe illness before we start providing services for less severe illnesses. And clearly, people with severe psychotic illness are not getting the services they need.
A very important point to end on. Well, thank you so much for your time today. We know how busy you are, and yet you make time to spread the word about these important topics. And thanks again.
Thank you for allowing me to come on this podcast and give my views. And I just finished. I do encourage anybody watching this video to look at the FASME website.